Thanks everyone for joining. My name is Scott Pally. I'm a child psychiatrist in New York. I want to introduce you to Dr. Clarice Kestenbaum and our clinical consultation team. For many, many years, Clarice has taught numerous child psychiatrists in the New York City area and who have spread all over the country and the world. And we're deeply indebted to her. And one of the most wonderful things she's always done, even after supervising us as residents and fellows, is that she continued to do a Monday night clinical consultation with fellows and attendings for many years. And many supervisors in clinical consultation, Clarice invited us to her home. She brought us pizza and a fruit salad, and we were truly felt taken so care of by her and so loved by her, besides the wisdom she gave us. So during the pandemic, she continued to do this. We had to buy our own pizza, but we had Monday nights with Clarice, and we still enjoy it. So we wanted to give everyone a little taste of what is amazing about consultation with Clarice, Dr. K. And we're going to present cases today that many mental health experts and clinicians can relate to, but they're completely made up cases. Dr. K is going to discuss them, as well as some of the other attendants in this clinical consultation rounds. All of us have been residents, medical students, fellows with Dr. K, and we continue to come to her throughout our years for her wisdom and expertise. The first person to speak tonight is going to be Dr. Olga Lebu.
So I'm going to start with presenting a case. This is a 14-year-old female named Natasha. Said she had a low mood. She's a female of Soviet Russian Jewish origin who immigrated with her parents to the US and was raised in the US since 3 years of age. She was living with her family on the Upper West Side of Manhattan in a small 3-bedroom apartment with her parents, her 2 younger siblings. She said she was attending a private school on scholarship and was in the 9th grade. She has the past psychiatric history, including 1 ED visit for suicidal ideation in 2017. She was in outpatient therapy for depression and anxiety since 9 years of age, and substance abuse, including marijuana and misuse of Ativan, for which she has also received outpatient treatment. That was in summer 2019. She was also in residential treatment for 1.5 weeks, and then at a dual diagnosis center and an IOP program for 2.5 months. She has past psychiatric history of substance abuse, generalized anxiety disorder, and major depressive disorder. She was referred to me by her father for medication management and therapy, and I finally saw her in March 2020 for ongoing outpatient care after a period of receiving medication from her pediatrician. The patient deteriorated and needed the higher levels of care before coming to see me. When she met with me, the patient reported doing notably better in terms of her substance abuse, but that she was drinking alcohol about 1 to 2 times every few weeks and vaping tobacco about 3 to 4 times a week. She did admit to using marijuana several times a day and Ativan about 0.5 to 2 milligrams daily before that period of time, for about 6 months, which led to the higher level of care. Despite improvement in her substance abuse symptoms, she noted that she still had a low mood and generalized anxiety. When she first started on her Zola 50 milligrams, she's had passive suicidal ideation a few months prior to seeing me, but no active plans. She did note that she ended up in the ER a few years ago because she did have a suicidal plan, which was to jump out of the window, but she was discharged. Her trauma history was positive for sexual abuse when she was in the substance abuse facility by somebody working there, and emotional abuse by both of her parents, along with bullying for years that started in elementary school. When I met with her parents, 1 week after I first met with the patient, the external world had changed a great deal, including for the patient and the family. The world was now in lockdown due to COVID-19 pandemic, and everything became remote, including the treatment, the patient's school, and work for everyone involved. The patient and the family had relocated to their old home in Westchester for more space for everybody in the house. At that point, the maternal grandparents were also living there. But initially, the thought was for the family that this was going to be a short period relocation. She did admit to superficially cutting herself for the first time, which was in January 2020. The family also reported being concerned about her minimization of her anxiety symptoms. They did believe that the patient again was engaging in some substance abuse behavior, mostly marijuana at the time. They denied concerns for patient having suicidal ideation, but they did say that she had that past history. They confirmed her struggles with panic attacks, but noted no concerns with social anxiety, post-traumatic stress, OCD, and everything that the patient mentioned, they corroborated. They noted her having a strong personality, that she was fearless. She liked to be more around boys. She's more of a tomboy. She had leadership qualities, but at points she was quite abrasive with those qualities. And it was hard for her to make friendships as a result. And in the home, they said that she was quite defiant, although in school she would actually follow the rules and wasn't a problem in that regard. In K through second grade, she did have some defiance, but then there was not a problem beyond that in the school setting.
Olga, you're giving a very good history of recent events and current events. What happened between age 0 and 3? Because I believe she came to the US when she was 3.
Yes.
So there is a strange picture. She's only 14, but at the moment that before going into treatment, it sounds as if really there's something that's deeply missing. And I'm wondering if you can know anything about those early years.
I think that's a great question, the 0 to 3 period. From what I understand, and the reason why they immigrated was in part they were Jewish, they were leaving as refugees because there was a lot of anti-Semitism going on in the former Soviet Union. Secondly, there was a natural disaster of Chernobyl that occurred at that point. And that was another reason why her family left. Besides those specific traumas, she was 2.5 years of age, and the family had her go with her grandparents for a couple of months to a different part of Russia. And that was a separation trauma that I certainly am aware of. So that's the extent of the 0 to 3 history.
I'd really like to hear a little bit more about her relationship with her mother and her father. Is she particularly close to one or the other? Are there arguments at home? Is she in the middle of any of this? Because somehow the picture doesn't really fit. That so much secrecy about the alcohol, the drugs, the pot, the cutting. I'm just curious about the person that she feels that she's bonded to or attached to. It sounds to me as if even if she had all the cognitive behavioral treatment or dialectical behavior treatment, that wouldn't be enough. There's something that seems very early, and it has to do with the relationship with, well, I don't know which one or all. She seems isolated. How do you find the transference with her, or I should say better, the relationship between you and her? How long has she been in treatment?
So she's been in treatment now for a little over a year.
Has that changed in any way from the beginning till now? Does she trust you?
In terms of her relationship with her parents, her mom struggles with self-injury. She has an eating disorder. Seems like she may have some personality pathology herself, maybe borderline. But again, I'm not her doctor, but that's what it sounds like, borderline constellation. And she had her at a very young age. She was 17, which in some ways was culturally appropriate at the time. So 17 was a little bit below the norm. And she met her father, and it sounds like her mother had her own abuse history from the grandfather, actually sexual abuse. When she met the patient's father, the father became like a father figure for the mother. But the father himself is a pretty intense, interesting, and warm guy to meet, but he has an intense nature, and as the patient sometimes describes, some narcissistic traits, which are palpable at points in the sessions with him. And so the patient was very young when mom had her, and she kind of takes on a role of the parent with her 2 younger siblings as well. She's like a third parent.
Are the siblings boys or girls?
The sibling, there's a boy and a girl.
This child had a lot of difficulty, it seems, if the mother is a borderline mother, is one where attachment doesn't happen that easily.
I guess I can talk a little more about that, the other question that you had about the transference and the countertransference. This is a likable girl. When I first met with her, our first session was actually on video. This was one of the first sessions that I had during the pandemic. I only saw her eyes at that point, and so I had to ask her to shift so I could see her room and her face. I playfully did that, and she was able to engage. So she definitely has an ability to attach, and I saw that right away. It takes her a while to trust adults. So she would come in, and again, to me, she minimized a lot of the history that I got later on from the parents. So that was something that I kept in mind, because she does take on this kind of gregarious, know-it-all persona and charming. On the other hand, there's definitely this vulnerable piece to her. And so my countertransference was that I want to help this girl. I see her potential. I see that she can get beyond her addictions and engage with the world and become an influential figure at some point in her life.
I don't hear countertransference here at all. I hear a caring physician who wants to help people and wants to help her. Countertransference, for me, although there are many definitions, means that it evokes some problem in one's early life. So I'm not hearing countertransference. I'm hearing very good physicianly care. There's a difference. It's a very interesting case. The girl is smart. I'm curious if the little girl and boy, the siblings, if one is preferred over the other. Thinking about, is the boy preferred for some reason more than the girl, because she seems to want to be boyish and seems to seek out the father more and wants to be tomboy, as you said. And I'm curious about the relationship of the parents or the father and the little boy.
Great question about the relationship with the father and the little boy. What I do know is that the little boy does have some similar traits to my patient. The little boy, later on, as my patient and I worked together, we did diagnose her with ADHD, and the little boy seems to really struggle with that very overtly, the hyperactive type. She certainly takes care of him, and she describes worry that he will be like dad to some extent, although she reveres but fears dad at the same time. So she has some worry about that. Her sister is only 2 years younger than her. There's definitely a competitive streak. She worries about her as well, because her sister, as we were working together and she turned 11, started to also engage in some cutting behaviors. And my patient worried that she's picked them up from her. Part of what she worries about is that she's transmitting the trauma that she'd experienced growing up with her parents who were young and had their own traumatic upbringing, and that now she's being just like that. She sees herself as another parent.
So she's a parentified child in many ways. And we know certain other things about her. She has a conscience. She has a superego. She feels guilt. In other words, you can throw out sociopathy and psychopathy here, even though she has all these problems with the addiction and with the, I should say, overuse of the marijuana and of the prescription medicine. We're putting together, it's a hypothesis of how did this girl, this lovely, bright, attractive girl, smart, how did she get to be secretive and display the symptoms, not telling, the cutting, the drinking? How did this happen? And where is it on the Ericksonian ladder of basic trust? It's a miracle that she has so much with you and not the other people she saw before.
I was thinking this is a great case in the sense that you could easily get lost in a lot of the superficial aspects of the disorders of substance abuse, or even the trauma that happened at the substance abuse residential. Or if you hear of a patient at a residential treatment center or hospitalized, there's so much sensational aspects that you can really get lost into any of those. Not to say that they're not important to be treating, but I think that there's something so core at such a more of a psychoanalytic idea of her. When I hear of all of her stories, I think of like she sounds scary. But then I thought to myself, she's really like a scared young child as opposed to a scary teenager. And as Clarice said, she doesn't really have the sociopathy. I mean, she's someone that really wants to attach, but she sounds so scared. There seems to be such a neglect in some ways. And just to imagine a 3-year-old experiencing, in maybe not understanding what's going on, but experiencing her parents and grandparents having trauma of the anti-Semitism, of the trauma of Chernobyl, and also the idea of going to another country where I imagine they don't speak the language that they came to, and she probably didn't speak English until maybe school for herself. The idea of going to a school and being very scared, I could imagine, and trying to figure out English that maybe is not spoken or even known in the home that she grew up in. She sounds like a really wonderful person to get to know and to help. And you can imagine why you want to really connect to her when you get past to some of the stuff that seems a little more sensational.
Olga, I'm curious in terms of mastery, is she someone that enjoys writing? Does she enjoy drawing? Like what does she enjoy doing or is proud of?
Yeah, I think both. I love your question, Betty, and Scott's pointed. But in terms of Betty's question, she's a writer. She enjoys writing. She loves to read. When times are rough for her, she reads. She likes fantasy, anime. The latest book was Thoreau that we were talking about, that she was both angry at and I think in love with at the same time. So yeah, those are her hobbies. She does not have a lot of friendships, and that's an area of weakness that we're really trying to build. And as to Scott's point, after the family moved to the US and the girl went to kindergarten, my patient, she was very excited to meet some friends. And what she recalls actually is that when she stepped into that class, nobody wanted to talk to her because she couldn't communicate. She could not speak the language. And then this was repeated again when she went to middle school. She moved from Monticello, New York, to Scarsdale, Westchester, and it was a very different community, and her style was different. She didn't fit into the upper class community of Scarsdale, and right away she remembers sitting in 6th grade at the lunch table and everybody standing up. So it was kind of repeated, that history from kindergarten. So it was really hard for her to make friends.
She's not able to put roots down anywhere. She's constantly uprooted multiple times.
And that repeated again sort of during the pandemic. So at some point, school in Scarsdale did not work for her. She was bullied, she didn't make friendships, and her family decided that it was time to make a shift. Mom was ready, and dad had a job in New York, so they decided to move to New York, to the Upper West Side. And then she got on scholarship into this really good private school, although it was all girls. She was excited about it. She wasn't necessarily excited about the fact that it was all girls, but she did well. She was doing notably better. And she was there in the fall, right before the pandemic. And so then the pandemic happens and she's uprooted, and her family moves temporarily back to Westchester, but it ends up 4 months later, they decided they're staying. She's still going to the school in New York. It was virtual. And the plan is for her to commute there from Westchester, but it sort of recreates a lot of the trauma of the past. She's back in the place where she was very happy to escape about 2 years ago.
Olga, I can't really think of any treatment for her other than a psychodynamic psychotherapy. There are secrets, there's longings, there's the imagination, the fantasy, there's Walden. She wants to be somebody to save the world one day, but she doesn't know how. She gets some relief when she takes the alcohol or the pot or the medication, because it takes her out of herself, because she's so unhappy in her current life. She's drowning. And I think that you're the lifeline for her, and it's very important. How often do you see her?
That's a great question. So I used to see her once, then we went to twice, and then the family really didn't want to, financially it was a burden, so we went back to once. But
once is not enough.
Yeah.
If there's any way, if you do once with even a touch base for 15 minutes in the middle, it's hard enough for her to trust and to have basic trust. And a week is a long time for a kid at 14-year-old. It's a long time. Twice a week isn't so bad. 3 times would be, I think, very good. And an in-depth treatment, because I didn't ask you, does she dream or have fantasies? I know the anime, and I know some of the books that she likes, but does she have dreams that she reports?
She has reported some dreams. We don't talk about them as much as we potentially can. I know we've spoken about a few, but she does speak about music. She does discuss some of her fantasies and desires through the music that she listens to. There are a lot of romantic relationship focused themes that I've heard, and sort of a heart being broken.
Is there any question that she has an identity disorder, as so many teenagers do, but they don't have to act it out in this way? She doesn't know who she is. She doesn't know where she belongs. She feels lost. Thank heaven she has you. Why you drink, why you take the pot, being depressed, unable to make a friend if that happens, getting upset when you're bullied. Those are problems that we need to talk about.
I agree. You always teach us this idea that it's really important to connect with your patient in the interim when they're away. So it's the summertime and she's been traveling a great deal. And we came up with a plan that she'd email me every week because she does have this intense history, but she's been doing better, much better. Her parents and I actually wanted her to have a normative teen experience this summer. And she had an opportunity to travel, and she's been in touch for 6 weeks every week. And I think that's proven immensely helpful, just that part. Just hello, we're in contact. And I think that's dynamic therapy.
It is. Olga, I think you're doing beautifully, really. All right, one last question. Do you like this patient? How do you feel about this patient?
Yeah, I really do. I know she could do very, very well. And I like her and I want her to do very well.
I believe that if she gets into more dynamic treatment, she'll have more of an existential dynamic analytic experience with you. She knows that she needs that connection with you.
Oh, thank you.
I wanted to thank everyone for watching. This was a great experience of having Dr. K supervise child psychiatrist who she's known for many, many years. I think it's so important to think about collaborating with other physicians and therapists and having mentors like Dr. K, who you can talk about cases with, and she could give you different opinions and different perspectives. It's been so enriching in my experience as a clinician to have someone like Dr. K, as well as colleagues, listen to what I'm doing and give their feedback and their support, as well as other perspectives, which is really an amazing experience to have in our field. And this was a great example of how we do that. We'll have future episodes as well where other people present cases. Again, they are made up cases, but as you'll see, a lot of them seem very real because we picked situations that many of us can relate to with our patients. So thank you for watching again, and looking forward to sharing new episodes with you.